Great. I think I'm unmuted, and I hope you can just see a single slide, my PowerPoint. Yeah.
Yes,
Great.
we can. Thanks so much, Kelly.
No worries, and hello to everybody joining online and to everyone in the room in Melbourne. I'm going to talk tonight on gender inclusive pregnancy care. Thank you so much to the Mercy Perinatal team for inviting me to speak tonight. My imposter syndrome is through the roof, but I'm very honoured to be here and to talk about a very important topic. I would like to start off by acknowledging that I'm presenting from Whadjuk Noongar country, and I pay my respect to their elders past, present and emerging, and I extend that respect to any First Nations people joining us tonight. I would also like to disclose that I'm an MFM fellow. I think I was promoted in the program for tonight, but I still have a few months left of training. And I wanted to highlight that this area around gender inclusive care is not specific to the subspecialty of maternal fetal medicine, but I think an important topic for all pregnancy care providers. I identify as a cisgender heterosexual woman. My pronouns are she, her, and I am presenting this data based on some clinical experience, a review of the literature and some community guidance. I aim to present it with respect and inclusivity, and I very much welcome any input, and particularly from those with lived experience. I have no financial or commercial disclosures. So tonight I want to talk about a clinical case describing our experience of caring for a transgender man in his pregnancy. I should note that I've really sort of stripped down this case and removed any identifying information to protect the confidentiality of our patient, given this, still a minority group and only a handful of cases across the country. I'll then touch a bit on some of the literature around transgender patient experiences, and then also provide some hopefully practical recommendations for the provision of holistic and safe gender affirming care. So transgender, non-binary, gender diverse and gender expansive people, which I will group together using an acronym quite consistent across the literature as TGE, comprise a vulnerable group in perinatal care. And studies have shown that TGE people desire to have children with rates comparable to the cisgender population. And in fact, studies show that most TGE people retain the ability to fall pregnant and their reproductive organs. We know that pregnancy among TGE people has increased in frequency and visibility in recent years, but there's actually still quite little clinical guidance and high quality data around perinatal care for this cohort. So our case was for calling patient A as a 30-year-old gravida 1 para 0. Was around 14 weeks when he was referred to a tertiary obstetric unit. He identified as a transgender male. He had previously had a double mastectomy, or often called top surgery. He had previously used testosterone and had ceased this around 12 months prior to conception. He had no recent history of gender dysphoria. He had a complex psychiatric history, had been stable on atypical antipsychotics, and was linked in with a perinatal psychiatrist. In the first visit, some important things were established. That his preferred pronouns were he, him, and his, that he was comfortable with technical labels or biological terms for his body. This was a spontaneous conception and a planned pregnancy with his long-term partner. Planned parental names and social supports were also explored in this consult. So I wanted to run through some examples of systems issues that arose in the provision of inclusive care for our patient. So one was that our electronic medical record was unable to reflect gender identity and was unable to code the gender identity as being different to the assigned sex at birth. This is a screenshot of the actual warning that came up that our midwife sent to me to say that she couldn't actually create a patient profile in our pregnancy database for this patient. The systems actually only allowed the sex or assigned sex at birth to be entered, and so we couldn't even create a profile for him initially. There was a lack of a gender-neutral patient toilet in the clinical space. A lot of the written information or patient information used very gender-specific language. There was some confusion over the pathology result reporting. So one was the confusion over the sort of registered sex of the patient and the use of gender-specific reference ranges. And in fact, the first time our patient had bloods collected in the pathology lab, he received a call later on from the lab to confirm his identity and asked if he had attended to get some blood samples with his wife. So that led to a bit of an awkward conversation. There were some various assumptions made from staff at different points that led to some awkward encounters. In fact, most of this was from non-clinical staff. Our patient shared some interactions with us, and one was, an orderly came to pick him up to take him for some investigations, and there was some confusion from the orderly asking where the patient was and asking if the patient was actually the patient's partner. Another example was that the catering staff were a bit confused and denied the patient a meal, saying that patients' partners were not actually eligible for a meal. So in order to improve the patient experience, various actions were undertaken. There were many meetings and huddles between key members of the leadership and management team. And this initially started down as quite a top-end approach. The meetings involved the Director of Clinical Services, the Medical Services Director, Unit Midwifery Lead, and Social Work. They mapped the patient's journey through the service in anticipation of what they might need and where they would have clinical encounters. And then under the direction of the unit leads, they were involved in educating their staff, providing some preparation and awareness for their staff in areas that the patient would come through. And a big component of this was engaging non-clinical staff, so admin support, and then patient services unit was involved in the education, as well as environmental services who helped to create some physical change to make the environments more inclusive. Of course, IT were on the phone many times to try and change our administrative systems and our clinical our electronic medical records. To get through some of the pathology confusion, there was an alert placed on the patient's UR to document his transgender male status. And with the patient's consent, we documented on the written request forms a transgender male patient and then some other clinical information that was relevant. A complex care plan was documented and circulated to relevant stakeholders, and an article that I'll touch on in a bit was circulated on multidisciplinary care for gender diverse patients, was circulated and actually uploaded to the patient's electronic medical record. We liaised with the operations team to change some signage in the corridors and create an all-gender toilet. And it was proposed that long-term we should develop some consistent policy to support consistent practice for future care for gender diverse people. The patient received multidisciplinary team care, so obstetrics, midwifery, perinatal mental health, physio and social work. As is consistent with the literature, one-on-one antenatal classes were arranged. He chose an MGP model of care, and this aligns with a lot of the data that comes out of the US, with the midwifery model of care being preferred. And I guess we know there's so much more data around about the benefits of MGP care for all patients, but particularly for those from minority groups or vulnerable population groups. A birth plan and postnatal feeding plan was made. The patient had a birth suite tour around 34 weeks of gestation, and particular attention was made in their birth plan for a plan around genital exposure and genital examinations. And a postnatal feeding plan was made as well. The patient went into spontaneous labour, had a normal vaginal delivery of a healthy baby of a normal weight. Postnatally, was debriefed, he had a marina for contraception and was linked back in with his mental health team for ongoing support. So the conclusions of the case was that there was some good outcomes and a really positive experience was reported from the patient and his family. I think for me as a fellow, this was a great learning experience and an example of effective interdisciplinary collaboration to ensure patient-centred and individualised care. The case prompted system and environmental changes in the units, and it improved a lot of knowledge and awareness of gender inclusion perinatal care. Looking at some of the literature, it's quite clear and consistent in numerous studies that TGE people face discrimination, stigma, neglect, and poor treatment in healthcare. And it's also known that they're less likely to obtain preventative care. One US survey, not specific to the perinatal population, but all transgender and gender diverse patients, almost a quarter of participants avoided seeking medical care due to fear of mistreatment. Pregnancy particularly increases the chance for gender dysphoria and loneliness. Many trans men are sort of confronted with the fact that they still have, a uterus, vagina, and they find that this increases their chance of, or increases their gender dysphoria. And there are many barriers discussed in literature around access to quality perinatal care. Those include institutional and individual erasure in perinatal healthcare. We've touched on some of these components already, but things like healthcare practitioner bias, lack of awareness, incorrect assumptions, obviously IT systems. The US data talk a bit about how in some states there are issues around birth certificates and putting different genders and sex of parents on birth certificates. And also out of the US data, interestingly, in some states, there are insurance implications because they refuse to provide healthcare or private insurance to patients that are choosing to have a different gender than their assigned sex at birth. The other aspect of erasure is the exclusion of transgender people in research and audit, which impacts outcomes quite significantly. We also know that the provision of childbirth-related care is really geared towards heteronormative, and this is sort of evident in our clinical spaces, the language that is used. In some of the qualitative data, patients talk about the difficulty even finding pregnancy-suitable clothes that are not suitable for people wanting a masculine appearance. And there's a lot of data around issues with breastfeeding, which I'll get to, and people being really fearful for feeding in public. The data around perinatal outcomes is actually quite limited. Most comes from case studies and cross-sectional surveys, and there's actually very limited high-quality data in this space. We know from US data that when we look at the locations of care, that transgender men had mainly chosen midwifery models of care. One series reported that about 40% of patients chose an obstetric-led model of care, which is quite unusual in the US system, and about 20% of patients had a home birth. The mode of delivery data supports that the majority of trans men in the published literature delivered vaginally, or some people prefer the term delivered genitally. In a large 2020 survey, sorry, something is beeping on my computer. In a large 2020 survey of about 200 trans men, about 77% delivered genitally or had a vaginal delivery. The data looking at obstetric complications and severe parental morbidity comes mostly from the US, but they report really quite similar rates of obstetric complications when comparing transgender patients with cisgender individuals. This table is from a 2023 study by Stromse et al., and they looked at outcomes in two large databases, so the Medicaid database and a commercial insurance database. And they compared over about 1 million cisgender patients and their pregnancy outcomes with a few thousand patients or transgender patients and their outcomes. They didn't find that there was a statistically significant difference in severe parental morbidity, which was their primary outcome. The data is a little bit difficult to interpret because of much lower numbers of transgender patients. They did find, though, interestingly, although this was a secondary outcome, that there was a trend towards lower odds of caesarean section delivery in trans patients compared to cisgender patients. Across the literature, it's quite clear that there is an increased risk of postnatal depression, about 35% in many cohorts, and this kind of aligns with data supporting a higher chance of pre-existing anxiety and depression in these patients. I think the qualitative data in this space is really important to look at. This is a really nice study that was conducted in the Netherlands by Amersfoort et al., and they published 5 in-depth interviews with trans men who had pregnancies. Some of the themes that they found really helpful included a healthcare practitioner openness and willingness to learn. They felt that they felt feeling seen, being heard, and the acknowledgement that they wish to carry a pregnancy as normal was really helpful. Confirming pronouns and labelling of body parts, not saying constantly that their cases were unique or special, and one participant described feeling frustrated that they kept being called a pioneer. They found sharing pregnancy experience with other gender diverse people very helpful and being linked in with support groups. And many participants talked about various books being helpful, and I've put up some screenshots of some books that patients found helpful. Trevor McDonald particularly has published a lot in the infant feeding and chest feeding space in the medical literature as well. Let's touch on language briefly, because it's really important to be familiar with sort of gender neutral terms that are very different to the cisnormative language that we always use. And this can be tricky. I mean, I think I've already said breastfeeding at one point in this presentation, because we're so used to using the cisnormative language all the time for our patients. But it's really important to be mindful of using language that would be more preferable to our patients. So particularly in the perinatal space, many gender diverse individuals would prefer not to use cisnormative language for vagina, vulva, and penis, and they would prefer to use neutral terms like genitals. Some would prefer to use front hole or pelvic organs. And it's just important to have that conversation with your patient to see what their preference is around this. Feeding is another example. So the gender neutral term for breastfeeding is chest feeding. Sometimes human milk feeding or infant feeding is also a neutral term to use. And I think many of us here do a lot of ultrasound. It's important to get the language right in this setting, and rather, referring to genitals and the fetal sex rather than assigning any concepts of gender or the baby's in utero. And the language in this space is very important. This is a really lovely study by Monica Hahn et al. And it was the study that we actually circulated for the team of clinicians caring for our patient. It provides a lot of practical support and suggestions, and it breaks down breaks everything into different areas. So they have a certain section on, making sure there's a safe environment, and advice around the non-clinical aspects of care in terms of admin, IT, legal aspects. And then it breaks the provision of care up into the preconception space, and then into antenatal, intrapartum, and the postpartum space. In the interest of time, I won't go through all of this article, but I wanted to cover a few specific areas. So looking at the preconception space and talking about testosterone. So testosterone is used as gender-affirming masculinizing hormone therapy, and many trans men or gender diverse individuals will opt to use testosterone. The recommendation is to stop testosterone therapy before conception, and this is due largely to theoretical concerns, but to the potential for the androgenic effects on the fetus with high levels of testosterone use in pregnancy. The optimal time is actually quite unknown and unstudied of when to cease the medication, but the international standards of care say for at least about 4 weeks. So this is the general consensus on advice. The data on this is quite minimal, but I think it's reassuring to talk to patients about the fact that testosterone use before pregnancy has not been seen to impact on fertility and perinatal outcomes. It's also really important to know that cessation may exacerbate depressive symptoms and gender dysphoria, and to ensure that your patient is adequately supported and linked in with psychological supports when coming off this therapy in preparation for pregnancy. In the postpartum space, I wanted to talk about newborn feeding. So it's really important to have a plan made antenatally and ensure that the patient feels well supported and has all options discussed with them. The data on this is quite variable. It's the small case series report about 50 to 70% of trans men in these studies have chosen to chest feed, but it's very variable. And for many trans patients or trans men, this can be a particular trigger for gender dysphoria. So really, it's considered by many as quite a significant gendered act, and many will choose to suppress feeding, to suppress chest feeding. It's important to know that even if the patient has had top surgery or a double mastectomy, they may still experience some chest growth plus or minus lactation, and to have a plan in place for support if this happens and lactation is not desired. Linking people in with a lactation consultant has been very beneficial in a lot of the literature, and the qualitative data on this does mainly support that many men chose not to chest feed because they felt a lack of support, weren't linked in with the lactation consultant, and felt quite fearful of feeding in public. Discuss various options of lactation suppression with patients, so pharmacological, non-pharmacological measures, and the other thing to sort of discuss as well is if some trans men will choose to utilise chest binding, and it's important to go through this. They may need to make some adjustments to how they're chest binding, because it can increase the risk of stasis in the breast tissue and mastitis. There's actually very limited data on testosterone in lactation. At the current step, at the moment, currently, the recommendation is to stop testosterone or to avoid using it in lactation. The very minimal data available does support that there's actually a really low amount that's transmitted in the breast milk, but the overall recommendation is to avoid it just because of insufficient data. It's definitely recommended to avoid it until the milk supply is established, and then to discuss risk-benefit balance with your patient. Other recommendations for postpartum include ensuring the correct documentation on birth certificates. If patients choose not to chest feed, you can restart testosterone around 4 to 6 weeks post-delivery. There's no good data on this, but it's been extrapolated from the advice we generally give around recommencing the COPCP, given the similar increase in VTE risk postpartum. It's really important to know that testosterone is not a reliable form of contraception, and there have been many unintended pregnancies reported while on testosterone use. So talking about reliable options of contraception with patients, so progesterone only is a good option. It's not thought to interfere with masculinization or continuing on testosterone. Important, as I've mentioned already, to link patients back into their community support and psychological support postpartum. So where to from here? I think it's very clear that we need a lot more data and a bit more local data. A lot of the data published is available from the US. We need to adopt gender-inclusive research practices, capture more patient experiences, and clearly keep working on some system and environmental changes. I always like the Mercy Talks when they provide some really practical suggestions for what we can change when we get to our office today or tomorrow. And I've just got some 5 points that I wanted to make in relation to that. I can't take full credit for this idea or these 5 points because I've adapted this from a brilliant talk given by a Dr. Justin Brand, who's a professor at NYU, who talks beautifully on this topic in the US. But point number 1, so introduce yourself to patients with your name, title, and pronouns. A really simple way of doing this is to wear a little name badge with your pronouns, adding your pronouns to the signature of your emails, and particularly in patient-facing correspondence. Ensuring clinic registration forms have multiple gender options and the ability to link this in with our IT administrative systems. Be mindful of gender-neutral language to use in the perinatal space. And then just know where to find some good resources. And I'll highlight a couple going forward. This is just a shout out to one of my colleagues, Dr. Sheba, who I work with here in Perth. She's organised these badges for all of us trainees. And she was really quite inspired to do this after she heard a talk at one of the Ranscock ASMs from a queer couple who spoke about their pregnancy journey and had noted that there wasn't a lot of queer support visible in the environment that they were in, and they thought that this would be quite helpful. She was also quite motivated after a video that she saw by Oslo Pride, and I've put up the QR code here for anyone who's interested, as it really just emphasises the importance of these small gestures and symbolism in making people feel comfortable in clinical and non-clinical settings. And I'll come back to this QR code in a bit. So there are quite a lot of resources if you get onto Google, but I thought this Resource Trans Hub was a good go-to place to go. It is an Australian website. There's a link also from here to Melbourne Uni if you're looking at trans-inclusive research practices. But this site really, it's got great information for trans people. It's got wonderful information for clinicians, and there's a bit down here at the bottom for fertility and reproductive health. So it's a really great go-to guide. There's lots of information also about creating safe environments, the languages to use, what questions to ask. So for me, this would be a great go-to reference when you're faced with a gender diverse patient. Rainbow Families has lovely resources for families seeking pregnancy. There's some great posters that midwives can use and put up in perinatal settings that are inclusive. Finally, so this very quickly, just to touch on this is a lovely guide for employers to use to ensure that their office or their environment complies to make it a gender inclusive and safe environment. So I'll end it there. I think I've just gone 20 minutes and I would like to make a couple of thank yous. One is to our patients for sharing their experiences with us so that we can learn and improve. The other is just to thank the team that I worked with on the case that I presented. I can't be too specific to protect confidentiality, but you know who you are, and I learned a lot about providing patient-centred care. I'm very happy to have any questions.
Kelly, thank you so much. That was a fantastic talk. Sorry, I know it looks like I'm looking out the window all the time. It's just the screen's in a different place. Kelly, thank you. That was a really very helpful talk. And I sort of feel like in some respects, maternity care has had to take the leading edge a little bit in this because the demographic that we are serving, I suppose general hospitals have it as well, but the majority of our population expect that we will have very good literacy in this area. And it's advocates like you that ensure that we do become much more competent in providing care, but also just in inclusivity for all gender diverse people. Kelly, it is quite shocking to me that you said 25% of transgender people report not accessing medical care, and that's borne out by the literature. And in fact, that's a very high number, really, compared to any other minority group. I'm wondering, what do you think the opportunities and barriers are for us? Because if there was any other group where we said 1 in 4 of those group will hesitate to seek any pregnancy care, we would be being very proactive to try and make sure that we made sure the hospital was a safe place for them to feel like they could have care. Do you think that we need to do better outreach, you know, both in the pregnancy, but also in the postnatal and feeding space?
Yes, I think so. I think it's complex and it's multifactorial, and I think you know, hopefully things are changing over time, and we'll see, and you know, people are being more inclusive in general in the community, in our hospitals. I think people are more mindful about inclusivity, and hopefully we'd see those statistics dropping. But I think it'd be targeted from multiple facets, and I think you know, I think we've got to engage with community and outpatient clinical settings to help bridge the gap between those settings and the hospital environment, because I know that in the metro, and I think it's also like, I know in the metropolitan settings, certainly in places like Melbourne, there are a lot more sort of trans-friendly GP practices and specific clinics being set up to target this in the community, but not necessarily in the hospital setting. So I think that the interface between those two areas would potentially help to bridge that. But I think just small things to start with as well, just making people feel welcome when they come and willing to open up to disclose all of their past and their history makes a big difference. And that's even just, like I said, the small gestures of changing our badges and having inclusive symbols in a clinical environment will hopefully help to make people feel safer. But yeah, it's probably not a one answer fix. It's complex, but overall, yes, I do. I think we need to be trying harder to reduce those numbers.
Yeah, and it does sound right that reconnecting both with primary care, particularly with the people who've got expertise and interest, who have a particular transgender care interest, is a good way to go. And perhaps also for some of the transgender care clinics, we should be also reaching out a bit proactively about if you are thinking about a pregnancy, so that they understand that we are wanting to provide the information and the care that they need. I think Ali's got a question.
Thanks, Kelly, for such a great talk. I have a question, and I know you're not the expert, but maybe in your readings you might have come across this. Do you know how much effort has gone into providing more education to people in training? Because of course we're all quite late coming to this, but there's medical students, midwifery students, nursing students, and if this is part of the general education up front, it makes it a little bit easier that they're knowledgeable and prepared much sooner rather than us learning off the back foot.
Yeah, it's a great point. I think, I mean, there's clearly in the literature, there's clearly a lot of talk about the need for this. There's no data that evaluates the success of these programs in a university setting or in our training programs. And to the best of my knowledge, I don't believe there's anything for us RANSCROG trainees, for example, yet. I think it would be a good space or a good module to create on our online learning. I do believe that there's some more teaching on this in medical schools, but I don't have I've heard this anecdotally, but I don't have the formal numbers around this. But I'd say there'd be hopefully, and I think there's a lot more there's a lot more work going on in that space.
Yeah. Yeah, that's absolutely true, Kelly. It is sort of being a bit built into curriculum a little bit more, but you're right that I think RANSCOG and ACMI, I'm sure, either are or should be looking at guidelines, and I can hear them ringing your phone right now. So please pick up. That'll be Nisha.
The other point, sorry, Sue, just for your first question, I just was thinking about what I think also ensuring that people not living in metropolitan centres have access to this care is utilising telemedicine. Yep. And that could be the way to help improve access to care for patients in this area.
Yeah, very good point.
Sorry.
Kelly, amazing. Thank you so much for a lovely talk.